Absolutely.
Good morning, everybody, and welcome to the UAB Informatics Institute Friday PowerTalks seminar series. Just wanted to let everybody know that this is a clinical informatics seminar, and we'll be talking about qualitative research. I know often these time slots are sort of alternating clinical and bioinformatics, but today is clinical informatics. So if you're bioinformatics, you may still want to stay for your interest, or maybe go to the next bioinformatics. So I'm really happy to introduce today's speaker, Dr. Ksenia Gorbenko, who is assistant professor in population health science and policy at and also the Institute for Healthcare Delivery Science at the Icahn School of Medicine at Mount Sinai. She is a sociologist and completed her Ph.D. in sociology at University of Pennsylvania with a focus on medical sociology, involvement in the AHRQ safety program for surgery, including ethnography, site visits, and interviews with healthcare professionals nationwide. She also has health policy training at the Dartmouth Institute for Health Policy and Clinical Practice, where she focused on investigating workforce design in accountable care organizations. Her current interests are in healthcare delivery and policy, patient satisfaction in oncology, patient resilience, and treatment adherence in inflammatory bowel disease, health provider burnout, which is a hot topic, and qualitative research methods. Also does a lot of teaching and research in these areas. In this talk, her student, Genus Nembeng, hope I'm pronouncing that right, will also be sharing her analyses in this study. The title of her talk, A Hospital and Google Partnership to Implement a COVID-19 Inpatient Video Monitoring Program, a Qualitative Evaluation.
Great. Thank you so much. Thank you, Amy, for the introduction and for inviting me. I'm very excited to be sharing this research. So this project came about from the situation that obviously was not that great. New York, as you all know, was the epicenter of the initial COVID-19 pandemic. And so basically some interesting collaborations came about, and we wanted to write about them and talk about them and really document what happened, because it was just kind of unprecedented. So yeah, let me go over some of these things. So basically what happened, there were about 2,000 COVID patients on the floors at 7 Mount Sinai or 8 Mount Sinai hospitals within the health system around April 2020. So that's a lot of patients that you don't normally expect. And additionally, about another 400 in ICU units. You, of course, all remember how terrible it was, but basically what happened, this surge of patients required a space. They needed to go somewhere, and they went onto units that were previously not ICU level. And these patients were also not necessarily ICU level, but they were unstable because it was a novel disease. We didn't know what to do about this. And sometimes patients deteriorated very quickly. So specifically, we had 2 units in the Mount Sinai Hospital that were just regular units, rehab and medical floor, that had doors. And I was trying really hard to find doors like this online. So there's apparently a vendor that sells doors like this, doors that had no visual, so nothing is transparent about them. And so this is an old floor, and it worked okay when there were no infectious patients on the floors, but it was a huge problem when it was full of COVID patients, because basically you can't see what's happening with them. If they deteriorate quickly, if they're pulling on their oxygen devices or their IV, nobody can see that. And the nurses, of course, are sharing multiple patients, so they can't be everywhere at once. The nurses were very anxious, and they came to their nurse managers and complained about this, like, can we do anything about this? And then it happened so that at Sinai, at the big hospital, and I'll talk about the other hospitals as well, just a little bit. Janice will actually talk more about another hospital within our system. But in the big hospital, somebody had a spouse who knew somebody at Google. And Google offered for free to furnish these Google Nest cameras on the floors and kind of help to work out a way to use them, to be able to see patients in their rooms. And they decided to try it. So the cameras themselves, you've seen them, they're on people's doors. I think they actually had the other ones, the ones that go on the walls. So they're direct to consumer cameras. They don't really have the same level of protection that you would need for medical data and for very vulnerable patients. You want to make sure that it's protected, right? So there were a lot of technical issues right from the start. But the idea was that it will provide eyes on the patient, save time, and I'll talk about examples of how it would save time, prevent adverse events, reduce healthcare workers' anxiety, and also reduce the use of personal protective equipment, which was in really low supply. There were not enough masks, not enough of anything really and everything. And there was certain procedures. If anybody has questions about that, I can go into details. But for now, I'll move on. By the way, I also would like to invite everyone, if you have a question, just feel free to post your question right away in the chat, because the worst that could happen is that you forget your question, and I would like to hear what you're thinking. I will not feel interrupted. It will be just great. So I'm a sociologist and a qualitative researcher. I work with my mixed methods colleagues on all of my projects, but primarily I lead qualitative evaluations and qualitative implementation studies. So in this particular case, we decided to interview workers who were involved in the implementation process of these Google Nest cameras on the floors. So we collected the data in November 2020, April 2021. So of course, there's a little bit of recall bias and maybe some people have left, but really it wasn't actually, it felt like it happened years ago, but it really was just a few months after the beginning of the pandemic. Now looking back, it seemed like it was almost immediate. We interviewed people on 2 units, and then we realized that we need to talk to other people involved in the project, like IT personnel who were actually figuring out how to make the network secure, what they needed, what upgrades they needed, and what needed to happen to make it workable, a workable solution. And we also added some leaders who were involved in the decision making, in the negotiations, in setting things up, and it was really insightful to hear their perspective as well. So we just kind of went with this multi-pronged approach to get as many stakeholders as possible. We did not interview any physicians, and we repeatedly asked nursing staff whether physicians would have some interesting insights, and they did not think so. So we basically just excluded physicians for that reason. And in reality, they were also very extremely short-staffed and overworked and burnt out at that point. So getting somebody would probably also be difficult, but we did not try based on our other people telling us we shouldn't. And then we analyzed data. I know that a few of you are probably familiar with qualitative methods, but perhaps others are not. So I'm kind of trying to also give you a little bit of an idea of the process, what we did, so that hopefully that will be helpful if nothing else. So these are the 2 units, rehab and a medicine floor. And this is our study team, mostly people from Mount Sinai, but we had a few external collaborators as well. So our semi-structured interviews, we started with interviews and things went great. However, we realized we needed to talk to more people, and we had somebody on the unit who would just kind of go with their phone. We had me or another investigator on Zoom, and we would kind of ask our questions on Zoom and record it. We realized that sometimes it's easier to get people in the same room if they're having lunch, for example. It's less disruptive to their work routine. So we also had a few, I think it was mostly nursing staff, sometimes patient care associates who were interviewed in a group setting. Everybody who was an IT or what we call leaders or administrators were interviewed individually. We noticed after a couple interviews that after a couple focus groups that it was good to have that dynamic of people kind of brainstorming off of each other's ideas, but they also spoke less about opportunities for improvement, which we also wanted to uncover. So they kind of tended to stay positive. And so we switched back to individual interviews to get those criticisms to kind of move the ideas forward. So this is our interview guide, and feel free to ask any questions. We basically came up with the domains based on the discussions that were had with the frontline staff. So we had concerns about these cameras maybe increasing the burden on staff, which would be a bad situation if that happened. We also wanted to hear about near misses, and there were some stories, but not a lot. And adverse events, if the cameras helped to prevent any adverse events, like that would be a near miss. And then we also kind of tried to ask around the idea that whether having the camera could give people a false sense of security. And it seemed like people thought it did not. But in general, we kind of just asked them about their experience, how it happened and how the process went, and what were some changes that were already made and that could have been made. And we discovered a lot. So in total, we collected 20 interviews, or we have basically 20 transcripts with 39 employees. And this is the approximate breakdown. MSH stands for Mount Sinai Hospital, and this is the main academic hospital. It's located in East Harlem. And MSM stands for Mount Sinai Morningside. It's a hospital that is a much smaller community hospital. It's located on Columbia University campus, and it used to be called St. Luke's. So if any of you remember or have been to New York, and you might know these locations, this is where they are. And we also interviewed somebody at Google to understand their perspective as well. And then once we got those interviews, we had them professionally transcribed. So every word was written down. And then this is basically the process of coding and qualitative research. So first myself, KG, and one of the other researchers, Afra Mohammed, AM, we were reading one transcript together and kind of trying to figure out to label everything that we are reading. It's called open coding, when you just label everything. And we developed 38 codes based on that. So we do it independently, and then we sit down together and try to come to consensus. So some of the labels get changed during this process to kind of agree on a common set of codes. And then we take those codes and we apply them to the next transcript. So at that point, you usually try to change them or kind of refine them, find a better way of describing them. And you also try to give a definition what each code stands for. And then we also developed some child codes, or we can also call them subcodes. And I'll show you examples of that. We had a third coder. It was Ed Eisenwaffer, who joined at interview 4. And I think by about, usually it's like a 5th, 6th, 7th interview, when after looking over several interviews, you kind of feel like you are grasping with your codes most of the things that are happening. And the code book can still change, but at that point it changes less. And so at that point we moved towards the software. We used, in this particular case, Deduce, which is an online qualitative analysis software that kind of allows multiple coders to share the same data set and see each other's coding and compare. So it's very convenient. So these are examples of codes at the top. I just took a screenshot of some of them, and we had, like you saw on the previous page, like 28. So like, for example, project timeline, anytime when somebody was mentioning when Google Camera came in on the unit or when it was removed. or how long it was on, or how long something took. So kind of the time in. And then patient safety is another example. And we have the subcodes here, like such as fall, oxygen supply, or near miss. And yeah, and basically what you see below are examples from the actual text, from the interview, from the transcript. And this was done still in Word. So initially we just coded in Word to be able to talk about the comparison and not to change up our code book too much, because it's kind of non-existent in the beginning. We are creating it. So we use this comment function to create it. So I'll read one example. In some ways, maybe it does slightly increase. I think the question here was about the workload and the burden on staff. And they're saying it's slightly increased because in the risk, I mean, we're catching maybe more things in advance. So we're having maybe to run in, like if someone sees something on camera, ultimately it's better for patient safety, but I wouldn't say decreases the workload. So you can also see how when people talk, there are a lot of run-in sentences. There's a lot of like kind of people start one idea and then they stop mid-sentence and they start saying something else. So this is what raw data looks like. And then in order to make it more comprehensible, we work on that and we show like cleaner, more readable quotes in the final paper and presentation. And then once everything was coded, we created memos. We wrote memos on particular topics. I don't think we wrote a memo for every code. Some of them were combined, but this is an example of that. You see some examples on the left, and the methods document got into there as well somehow. But for example, on the right, you can see prioritization of care. So there were 8 codes or 8 quotes probably from several interviews. We forgot to put from how many, but we usually try to keep track how many interviews we actually mention in this particular code. And that's because our sample and qualitative research is never representative. We do this for our own confidence. How confidently can we say that this is what people are saying? And for that, in order to not confuse the reader that this is representative, it's never representative of anything. We're trying to understand causality rather than have any kind of representativeness. So we usually try to say how, like in vague terms, the majority of people said X, Y, and Z. Because if we say 8 out of 10 people, you and I and everybody who reads it will feel that it's 80%. And that's not the case because there are no percentages in qualitative research. Don't quote me on this, but actually I will stand by that. All right. So prioritization of care. So for example, so first we describe in our own words what is happening in all the quotes that are about prioritizing patients during monitoring. So respondents described how they organized patients on the screen to be able to highlight the high-risk patients versus the low-risk patients, right? And so there's an example. So there was a training, there was a special log. They also had the assignment of the unit. They were able to see who had what patients. So they knew the people who were watching the screens were able to see which nurse is assigned to the patient on that screen. Some of them, we wanted them to keep an eye on closer, those with high flow oxygen devices. So we actually had earmarked which patients in which rooms they needed to watch more closely. So this was a constant work in progress. Every day they would mark the high-risk patients. And there were actually additional changes that were made for that as well in terms of technical upgrades and technical differences. So there were multiple patients on the screen, and you can't see everybody at once, right? There's one person watching them. And there was also a problem on one of the units. They didn't have enough network capacity to have all of them in a constant video feed. So they actually put the low-risk patients on every 5 seconds. There was a picture. So it was like a snapshot every 5 seconds instead of having a continuous video feed. But they fixed the network capacity after that, and the other unit never mentioned that. So this is the actual handoff sheet that they created. And you can see, so you can see that there were 2 patients in the room, 101A and 101B. There was 1 camera per room, so you would have to kind of watch 2 patients based on that. And they would have the phone number for each patient. The reason they had a phone number is because the cameras have the microphones, but they were far enough and it was very loud because of all the air cleaners in the room and the oxygen machines, that a lot of the times the patient and the person watching them on the screen could not hear each other. And the phone was a simple solution. A lot of these patients were not ICU level, they were conscious. Most of them were conscious, but sometimes they did pass away and they sometimes did deteriorate significantly. So it was kind of a variety of acuteness level. And you can also see they can mark here what kind of oxygen device they're on, and depending on the level, they will be watched more closely. And also they could be marked as high risk. So here, so basically we had a lot of data. There was so much to analyze, and we decided to focus in this big umbrella paper on adaptations and opportunities for improvement. So adaptations are basically all the things that they did to improve the work of these basically consumer cameras and to make them workable for healthcare. And you can look right now and ask me about any of these. I won't be able to cover all of them, but I'm happy to discuss if something looks interesting or directed, maybe related to your research. Feel free to ask, and I'll expand on that. And I have a few examples also that I selected that we can go more in detail. I'm going to give you a second to take a look. We also, I will talk about the broader topics. So basically we had technological issues, which were usually, we discussed them with the IT personnel. They knew about all of this, all of these upgrades. Although the nurses also spoke about the privacy function that was added. For example, initially they would just put the like a sticker on that particular screen if they knew that the patient needed privacy, like had to be changed or something else like that. So the nurse in the room would say we need privacy, and then the person watching would put a sticker, and then they had it upgraded to a way that you can black out the screen. There were multiple legal and regulatory things that they had to do, but they were able to start the process and sign the contract in 2 weeks, which is incredible. They said that without COVID, it would have taken 6 months to go through legal departments and everything else. So consent is an interesting thing, because a lot of patients arrived on these units a little confused and maybe not in their best cognitive ability. They were all consented, but they might forget about this. And there were a few cases where patients would feel better and realize there's a camera and ask for it to be turned off. So that did happen, although very rarely. And it happened a lot more when the units were turned from COVID to non-COVID. Now I'll cover that as well. So this is one example, using this video feeds as a backup monitoring system. So this is a nurse, most likely speaking. Well, a lot of the times we are very busy with some critical patients, and it takes us extra time in another room. So if we don't hear the PCA, patient care associates, that is monitoring the camera, calling for the nurse for another of our patients, we assume that everything is okay and that gives us extra time to spend with this other patient. So basically, they felt confident that someone else is watching their patient while they're working with this critical patient, while they are spending extra time with one of their patients. And that was not the case before the cameras. I see there's a question. Are the adaptation categories on previous slide themes that came from the interviews or were they created before the project started? They were themes that came from the interviews. I think, let's see, maybe some of them, let's go back and look. We did specifically ask about the workflow, but the themes that came up were kind of coming from the data. I would say that the larger themes kind of came from the data as well. Yeah, especially things like infrastructure. They talked a lot about this. We knew it would be about technology and patient monitoring, and that there should be some kind of workflow adjustment and creation of a new workflow. But the interpersonal relationships and infrastructure came up kind of almost, you know, we knew less about it. We expected it a little less, although we should have. This is another example of patient acceptance of video monitoring in non-COVID context. Like I said, people, once COVID subsided, the union became non-COVID, and we just had regular patients up there. We started getting complaints like, why are there cameras in the room? Why are you monitoring us? And so on. And so on COVID units, no one, this person says no one, but we actually had other staff saying that there were a few people complaining, and not many. No one, and they're saying no one had any issues, but we did have that one. This was back in the spring unit that went from COVID to non-COVID when we were coming down from the surge. And under normal conditions, the patients were not, and maybe we didn't message it very well, but the patients did not want to be on camera. And so for anybody who wants to think about this inpatient use of cameras, maybe not Google Nest, maybe something more applicable to healthcare, it's a question, right? Will the patients agree to this? And there were other failed attempts of this, like 10 years ago, of tele ICUs where the nurses hated it and they didn't want to be observed while working, and they would unplug the units. So it's fascinating when people would agree to be watched and not, and it could be a whole other topic on its own. And then we also identified opportunities for improvement kind of in the same domains except for workflow, because it's we didn't have a lot of opportunities for improvement in workflow. By the time we interviewed them, it was a whole year has passed, and I think they nailed it down. Maybe they felt that the workflow was good enough and they didn't have much to say that needed to change. Although if other processes are changing, there probably would need to be adjustments. So feel free to also look at this, and if you have some questions, I can also flip back to this if you have questions later. This is an example of the effects of built environment, so this infrastructure kind of domain, camera position related to outlet location. So one clinician says, yeah, but there are blind spots. So if it's only facing the bed, you can't see to your left. So if the patient leaves the bed, you won't be able to see. And again, these patients, some of them were not getting out of the bed. Some of them were on high flow oxygen. And if they did get out, they could fall. And others could go to the bathroom on their own. So there was a diversity of levels over there. And then I think it really, this is a leader speaking, I think it really is the camera location. And of course, that may be contingent of what's available in terms of power outlets in the room as well. And this is such a simple thing, right? But you are basically, the camera has to connect to an outlet. And if it's not far enough, it also creates trip hazards if you have to put some extension cords and things like that. So it seems very basic, but it also affects the way you install these things. So this is the paper that was published from the presentation that I just shared with you. But I also would like to ask my colleague and my collaborator Janice Nemberg, who is actually is a PhD student at Mount Sinai, to talk about her research, and maybe I'll go back to some of the takeaway messages after she discusses what she's done. Yeah, maybe Janice.
Yeah. Thank you. Hi, everyone. So now I'm going to give you a brief overview of the secondary analysis we did with the same data. So basically, after the completion of the first article, we looked at the data with a second eye, and we realized that there were like another aspect that we could explore. So the first paper focused on the video monitoring at Mount Sinai Main Hospital, but a little was said about how the whole implementation came to be. And we also realized that little was known about the use of video monitoring in another Mount Sinai facility, Morningside. So with that in mind, we thought it could be a good starting point for a second paper. And we wondered how we could explain the implementation process. And we find that very interesting conceptual framework called the CIFER, that stands for Consolidated Framework for Implementation Research, which is like, in short, just to like a framework to help assess multi-level implementation. And that's the one that you're seeing here on the slide. And we specifically focus only on the process part of that conceptual framework. Slide. Thank you. So after looking at the data, the same set of issues motivated the implementation of video monitoring in both facilities. So for example, the implementators reported that their staff complained about the inability to see patients, the desire to avoid risk associated with COVID exposure, and the need to reduce the use of PPE supply as well. And we also realized that we didn't necessarily need all the interviews of the original paper, and we only focus on interviewees who were actively involved in the implementation process. Slide. So at Mount Sinai Main Hospital, because they already had, like Dr. Gorbenko stated before, a direct connection with Google affiliates, they gathered a group of stakeholders composed of Mount Sinai leadership, Google affiliates, project manager, lawyers, and clinicians to be able to try to brainstorm about how they will be able to set Google Nest camera in non-ICU units. And so after a couple of days of collaboration, they came with what they call the console that you can see here on the picture, which was basically a system that allowed them to have like continuous video feed on the patient that they needed to take care of. And they did have some obstacles along the way. And every time that they were facing them and having feedbacks from healthcare professional, they would troubleshoot and try to improve the system. Slide. So at Morningside, Mount Sinai, that you can see on the picture on the top left, they didn't have in the beginning like a direct connection with Google personnel, but they had a structure called the Lean Lab. It was basically a structure that allowed periodic gathering of stakeholders to find solutions that their facility might be facing at the moment. So instead of a straightforward approach, they went with a more stepwise type of approach. So they started, so like you can see on the figure, they were starting with one solution, and if it wasn't working, they will loop back into the Lean Lab to try to brainstorm and find something else, and so forth. So they first started with baby monitors, but then they realized that the image quality was not optimal, and that was, and also that it wasn't necessarily following the HIPAA recommendation when it comes to patient privacy. And then they tried to externalize the monitors. And as a reminder, it was in the middle of the pandemic, so the patient's relatives were not in the department, and the video feed and vitals display were only for the healthcare professionals who were taking care of the patients directly. But with this approach as well, they realized that they were facing obstacles and they went back to the beginning and went back to the lean lab to try to find another alternative. They even had at some point access to a limited number of Google cameras, but at the end of the whole process, they choose to use plexi doors as a final alternative. So yeah, so that's pretty much what we came with our secondary analysis. Thank you.
Thank you, Janice. Yeah, and yeah, it's basically they had some major problems, but in the end they told us that they would like to upgrade every patient room to ICU level. Of course, who has these resources, right? But because another crisis and another surge will happen, and this is kind of the situation that we're all in, that needs a solution in advance before things are happening. I want to go back a little bit to talk about some implications. Yeah. So I'm going to say this was the first case, but with a very big caveat to our knowledge of using direct-to-consumer cameras in a hospital setting. Because, you know, even looking at this experience of Mount Sinai Morningside, as you heard about, like they're trying to brainstorm and running for baby monitors, like similar situations are probably happening in some other parts of the country. We just haven't heard about them. It seems like it was kind of percolating everywhere, the same problem, trying to find a solution. And then other contexts for video monitoring really need to be explored. There could be other patients who would benefit in terms of patient safety from being video monitored, such as on brain injury units, patients with delirium or dementia, or on certain kinds of medications. We also realized adaptations take a lot of time, and so doing something like this, creating a workflow, creating the process of quick installation and quick rollout of some kind of cameras, it would be great if you can do it before the next crisis rolls around. Integration with existing systems, like even phones, like that workaround that they created, or iPads that a lot of hospitals are using these days, or Vocera that maybe, I don't know if they're used at UAB, but are used at Sinai for sure. All this integration requires the input of both the technicians, the IT personnel, but also the frontline staff, how they're using them exactly, which way should it be adapted. And then we learned that acceptance by patients and clinicians is context dependent, like I told you about the COVID and non-COVID units. Nobody on non-COVID units wanted to be monitored in this way. We really need to be transparent and upfront about when the camera is there and what it's about and how it's going to help the patient and the nurse actually as well, because they might also protest being observed during their work. And then, of course, that advice from one of our leaders was that we need the ICU level visualization. So we probably need transparent doors on new units everywhere, and that might at least help to some extent. The problem with the doors was that they wanted to upgrade, but like the doors they chose were not fire hazard ready. So there were like a lot of compliance issues that in the hospital you have to deal with that were not allowed. So in the end, they actually created a plexiglass door, but it was the second door. So there was still fire safe door that wasn't transparent on the outside, but they put a second door on the inside. It's really complex. And investing in video monitoring now to be able to quickly scale up is probably a good idea. So I'm going to stop here and open up for questions.
Thanks for the great presentation and, you know, kind of important presenting how to monitor people during that very scary, uncertain time of the pandemic. So feel free to unmute yourself. I think we know most of us here, and or you can enter your questions in the chat. I do see some questions in the chat. So
Yeah,
there was the one from Dr. Vesculitis. Are the adaptation categories and previous slide themes that came from the interviews, or were they created before the project started?
yeah, I think I tried to address that during the presentation, but yeah, basically, for the most part, they came from the data. Those categories came from the data.
Yeah, in your experience, can you discuss pros and cons of in vivo versus deduce?
Yeah, I'm happy to talk more if there's a particular interest, but in brief, I have two software options that I usually recommend to people, and it's Deduce and MaxQDA that everybody seems to really love. And Janice, for example, analyzed in MaxQDA. I love Deduce because it's flexible in terms of being relatively cheap per person per month. That's how you pay for it instead of buying the huge license, and they keep upgrading it, so you never have to worry. With in vivo, you have to worry that your license, even though it's for life, it will become obsolete. I do have actually two versions of in vivo, but I kind of stopped using it. I usually show it to students in class, but it's a little, it's good, and it has slightly more functionality than Deduce, but the inability to open a file from a Mac on a PC computer or from PC on a Mac is a huge problem for me, because not everybody has the same type of computer. MaxQDA does not have that compatibility problem, for example. So I have moved away from in vivo now, but you know, it definitely has its uses. It's also a little bit more bulky for, it's basically always more bulky when you have more than one coder, which is the way I work. I always have more than one coder. Even when you have the same version and the same license or multiple licenses, but like the exact same version of in vivo, it might not open files for comparison in a good way, and you have to make sure that every code is spelled exactly the same, and if there is a space, it won't read them as the same. So it took us multiple days sometimes able to compare coding, and I'm kind of beyond that. I hope that answered your question.
Yeah, looks like it did. Other questions, comments?
Ksenia, I'm just wondering who the biggest champions of doing this were at the hospital, and who stood in the way. It sounds like the nurses and the patients sometimes stood in your way, but like, who was trying to champion it to make it happen?
Oh, that's really interesting, actually. I think so. We interviewed one nurse manager who was a huge champion on that. She kind of she didn't initiate, she didn't have that Google connection, but she wanted to have any cameras, any eyes on the patient. And that was because her nurses were very anxious, and they came to her like in tears. We can't work like this. We just don't think we can provide good care. We don't know what's happening behind the closed doors. And so that nurse manager was a huge promoter and champion of that. There was another nurse manager on the second unit who was also really into it initially, but she went on maternity leave. And when she was gone, the other person who took over was simply given the cameras. So there was a lot of less enthusiasm for the cameras on that second unit, because it kind of came from the top, and it felt to them that nobody really asked them. So there was a huge difference here. But I think for the most part, the nurses were very enthusiastic and on board.
Thank you.
Has there been feedback from about these systems just not during pandemic times?
They took them off. They returned them to Google. They were kind of on loan for free from Google. The moment the wave of COVID subsided and there were non-COVID patients on the floors, they didn't want it. And there was a little bit of time when the cameras were still there and maybe they were still used to an extent, but they got such quick, rapid pushback from the patients that they just took them down and took them away. And I think there was another wave. I can't remember right now it was still within the framework when we were interviewing within that year. There was another wave when there were some overflow of COVID patients and the cameras came back. And one of the complaints, or one of the things they asked us, we just wanted to be plug and play. We wanted to be much easier because the installation and the connecting it to the console was kind of a lengthy process. They needed to have these technicians coming in for a long time. So they needed to be like made specifically for this purpose. So they just plug it in and here it is, and it was not like that. Yeah.
Oh, okay, that's interesting. Be nice to know, how it contributes to care at any time, not only during a pandemic. And I was also thinking about so many places are doing tele ICU care that they involve cameras. So it's interesting to hear that feedback.
Yeah. No, it's fascinating because I think there is an opportunity to still message it in the right way and talk about it in the right way that the patient will embrace it. But I think it's kind of like you need to come up with that idea, like people need to be aware and know what's happening, why it's there.
Yeah, I think that's a really good point. And I'm just thinking, as you said, like it would be great to be prepared for the next, right? But like the technology is going to be changed, like it changes every week almost. I feel like we can't really have that stuff. We can't invest the money in it because it'll be different in 6 months or a year. But having the way to sell it to the patients and to the nurses and to the doctors is maybe what we really need to work on, because that's not going to change, is my guess.
Yeah, because the cameras are evolving, you're right, on their own, like for consumers. And so, I guess having a healthcare product would be great. I've seen some, like there are some cameras and they exist like in conference rooms, the cameras that are able to kind of turn around and look at everybody in the conference room. I don't know how much they're used these days, but something like that exists. These are usually pretty expensive. So it also needs to be like plug and play, cheap, like, so there's an opportunity, certainly.
Any final questions, comments?
Hi, this is Srini Tridandapani, one of the radiologists. Thank you for this fascinating presentation. Now, it looks like you've already published something on this. Can you put those links in the chat or something if that's possible?
Yeah, I'll do that right now. Yeah.
So one of the things that we have actually developed here are ways to capture patient photographs along with medical imaging studies. The idea is that as radiologists, we are divorced from what's happening to the patient. We just see inside the patient, but we don't know what is happening outside. So, to be able to correlate things like lines and tubes and, all these sorts of things that you would see on an ICU patient, it's really helpful for us. And I think, many of the challenges that you're talking about, we have noticed in terms of the technologists under the impression that perhaps we put this cameras to monitor what they're doing, and that's really not the intent. But those are things that people think about, and you sort of have to get ahead of the challenge before it happens. You kind of have to ward that off, and I think your message about doing the right messaging, getting buy-in, and getting everybody on the same page on the goals is important. So thank you for putting all of that together in a very fantastic talk. Appreciate it.
Yeah, thank you so much. Thank you for your comments. And I think what you said also about the having the pictures of patients, but kind of not seeing the context where they're taken, and that's really fascinating. I think it's being able to, maybe these talks would actually help, but I think being able to bring somebody who's in radiology, who's looking at these pictures day in and day out, and then take them on a tour of the unit, you know, is the particular, maybe like it's cancer patients of particular kind of, or somebody else, right? And being able to see the context might actually generate ideas for how else you can, what else you can do with that, right? Yeah, I see another question. Is there a body of work out there which demonstrates that having video feeds to patients improves care? And if so, on what types of units? And how would you control for patient nurse acceptance in order to study that? So when we looked up, we tried looking up in different ways. So this was like 2021, primarily when we were looking things up for the publication. So there could be something more recent that still came out. But basically we ended up, first we called it remote patient monitoring, but that's not it, right? Because remote patient monitoring is more like collecting vitals and sending them remotely through Wi-Fi or a hub to some other location where the clinician looks at them. So we ended up with this term inpatient video monitoring. And on that, there's actually not that much already done. So we probably do need to evaluate, like you were asking probably more. An outcome study like that would need to be set up correctly. And you were saying like a more strict, like a randomized trial. I think we're probably too early at the moment. I hazard to say we need to actually adjust it to the needs of patients and nurses first, and then probably evaluate how it affects outcomes. We got to the point of semi-acceptance or acceptance in particular circumstances, right? So like as long as there's COVID and they're all terrified, they will agree to this. But if it's not life-threatening, they might say no. So yeah. Does that help, or do you want to clarify, Curtis?
Other questions or comments?
Yeah, you were saying, sounds like the answer is no, not yet. Yeah, I agree. Yeah, it's early. So there's a lot of opportunities to study this.
Well, hearing no questions or comments, can always reach out afterwards. I know how to reach Dr. Gorbenko. So thank you very much for the wonderful presentation, and thank you for attending and for your wonderful questions. And we hope to see you at the next Power Talk. Have a great weekend.
Thank you so much. Thank you for having me.
Thank you.